committees to be established, the advisory committees that are linked to the fund, general provisions, complaints and appeals, any financial matters that are related to the fund, and then finally the miscellaneous issues that may be relevant. I think before I just get into the actual meat of the bill, just a couple of points. I know that this may have been out in the media, and sometimes it's what's at the back of people's minds when I speak, and maybe I should deal with them up front and clear them out. The NHI will not in any way affect the ownership of practices, private practices, that is. So everybody who owns a private practice continues to do so. It's the property of the person that's practicing. There is no intention to nationalize or anything like that. Secondly, I think it's important to understand that it's a mandatory prepayment system, and so there is no taxes that you're going to pay more than what you are currently paying through your current medical scheme type arrangement. Thirdly, I think this concept that there would be an SOE which would effectively be ESCOM-like in terms of the way it would function is also not true, because it's what we call a Section 3A public entity, and I'll talk more about that just now. I thought I should just clear up some of those issues, and to say finally that the medical schemes will continue to exist as they exist now. They will continue from now until the NHI is fully implemented. At that point, they will not offer duplicative cover. That's the only difference from what happens from now and when the NHI is fully implemented. There's a date in the bill about when we think that will happen, but there's also some steps that we need to get to in order for that to happen. I'll talk more about that. So, in terms of the purpose of the Act, this Act is intended to establish a fund. In terms of law, we have to, before we can actually start transferring money into a fund in government, we must establish it in law. So the intention is to establish the National Health Insurance Fund. And the fund will be financed through what we call mandatory prepayment, which simply means through various forms of taxation. And the intention is to provide access to all South Africans to have quality healthcare services. And this fund will be a single purchaser and a single payer of healthcare services. So that structurally is the way the fund will operate. In terms of its application, it applies to all health establishments in the country, as well as all providers of healthcare, except the military health services, given the nature of the military health services, and the state security agency. So those are the two exclusions. What this does mean, and somebody usually asks the question, is that this means that members of parliament will have to have the same medical scheme as everybody else, and the president's very committed that that must happen. So no separation out from what currently exists. Now, this piece of legislation is going to take a long time to implement, and we're anticipating that by 2026 it'll be fully implemented. Given that it's going to happen in phases, we have provisions within the legislation that allow us to bring in these provisions year on year, so clause by clause. So this is not a big bang that will happen next week or next year or even next month. It's going to happen in stages very slowly, depending on a number of factors that must be achieved in order for this to happen. So in terms of population coverage, who will be covered? Well, all South Africans, legal permanent residents, refugees, inmates, as well as specific categories of foreign nationals that the Minister of Home Affairs may designate, may be entitled to benefits. Asylum seekers and illegal migrants will be entitled to emergency medical services, notifiable medical conditions, and basic healthcare services for children. Services that fall outside this scope will then obviously have to be paid on a cash basis or an insurance basis or take out medical scheme cover. Foreign nationals that visit our country can either take out some sort of health insurance, or they may, if they're staying here for a longer period, have some sort of medical scheme cover for a longer period of time. In terms of the registration of users, here the users of the health system must register with their primary care providers. Given that I'm talking to a dental audience, the idea is that they would register with a dentist, for example, where they would be seeking care. The fund will then contract with that provider related to the number of potential members that would be accessing care at that particular provider. So the idea of the registration is to identify your provider so that you would then be able to access care, and we'll be able to contract with that provider. In terms of service coverage, the intention is that the user will enter the system at the primary care level and be referred up the chain in terms of higher levels of care. We also have provisions relating to our central hospitals, where we're saying that our central hospitals should become semi-autonomous business units as such, so that they operate independently of national or provincial government and are able to perform any of the functions that are needed. Clearly, the fund will not be able to fund everything for everybody, given our current economic status. And so the fund will obviously have to exclude interventions that have no medical necessity, where it's not cost-effective, or where they're just not within the formulary which would be developed. Clearly, if something is not within the benefits package, there will be an appeals process where the public will be able to engage with that. The bill also adopts a rights-based approach around access to care, where it says all South Africans have the right to quality healthcare services, and this should be free at the point of care, meaning no co-payments and the like. That information relating to the fund must be provided to all members of the public. They should be able to understand these service benefits as well as any personal information that may be appropriate. They should not be refused care on unreasonable grounds. Neither should there be unreasonable waiting times for them to access care. So the intention is the fund should be able to finance care and provide access within a reasonable time period. They should be able to make reasonable decisions about their health care. And where people are aggrieved with the type of service that they received through the fund, they will be able to register a complaint with the fund, and the fund has an obligation to respond within 30 days to such a complaint. And then there's a process if that complaint is not resolved through that process. Where these services are not funded through the fund, South Africans can certainly purchase some form of complementary medical health insurance, or medical scheme cover, and the like. Moving to part 3 of the bill, which talks largely about the type of fund. So this fund is what we call a Section 3A public entity. So those that are not familiar with that, it's a very limited financial structure within the Public Finance Management Act. We have about 163 Section 3 public entities. Your ESCOMs and South African Airways and the like, which have been in the news for all the wrong reasons, are what we call Section 2 public entities. They have the right to take risk, to borrow money, to get into business deals, etc., that this fund does not. So this fund will only receive its funding from one source, and that is from Parliament through appropriations, and it can only do one thing with that money, and that is to get into contracts with healthcare service providers in order to pay for services delivered. And so there's no opportunity to go outside that narrow scope of what its role is. It clearly must purchase services, it must reimburse providers in a timely manner. During the comment period, a lot of providers were concerned that maybe they may not be reimbursed in a timely manner, and so we've included this in the law to make sure it's a deliverable of the fund. It should clearly be appropriately funded at various levels of care, provide monitoring of the quality of services so that South Africans understand the type of service that they're getting and they can monitor that. There should be a pay-for-performance model in place so that we encourage providers to deliver services based on a performance-based reimbursement. It will also monitor the impact of the fund in addressing healthcare needs and maintain a database of both epidemiological as well as demographic data and perform functions that are in the most cost-effective and efficient manner. The fund will have to align to national policies, which will be set by the minister in terms of protection, promotion, improvement, as well as maintenance of health of the entire population. Moving now to the board, and Section 3A public entities in terms of the law must have a governance board. And so this board that has been proposed has 11 members with a range of skills within the board, such as financing, health economics, public health planning, etc. The board will have a 5-year term. The proposal is that the minister will advertise these positions. Members of the public will submit nominations. He will appoint an ad hoc panel that must publicly interview people that are interested in being board members. So there will be some public engagement around who it is that will be interested and who could potentially fill these positions. And at the end of that, the panel will make a recommendation to the Minister on who would be appropriate appointments for the board itself. The board will have a 5-year term and will be renewable only once. Then we have the CEO, and the CEO, like most CEOs in the state entities, would be appointed based on technical and competence as well as experience. The board would interview such a person and will then nominate to the minister that he or she has a 5-year term, renewable only once as well. And the board would recommend the removal if such a person is not performing his duties. Clearly, this person will report to the board itself, and he or she must run an efficient administration, maintain services such as human resources, etc., within the fund itself. The fund should have a minimum set of units which the CEO must establish, such as a planning unit, benefits, provider payments, contracting, accreditation, purchasing, etc. And the intention is that this efficient organization is the responsibility of the CEO. We've then established 3 committees that are outside of the fund in order to balance the powers between the fund and stakeholders. To have a benefits advisory committee, which will be intended to come up with guidelines and benefits as to what the fund will be reimbursing and how that reimbursement will happen. The idea here is that largely clinical disciplines will participate in that, in setting up clinical protocols about how a particular disease will be managed, at what level it will be managed, etc., what would be the reimbursement for that. And all of that would happen as part of this benefits advisory committee. So we would see, for example, the dental benefits being put together by those that are knowledgeable in the area. Then we have the pricing committee, and its role is basically once the benefits committee has finalized the benefit, the pricing committee is expected to negotiate with providers of services, of goods, etc., come up with what would be the cost of this service and make sure that it is within the budget that's allocated by the National Treasury. Because each year there'll be a fiscal allocation, and the fund must stick within that fiscal allocation. So this committee will then engage with that and then share with the Benefits Advisory Committee what its anticipated expected cost of services would be. Then finally, there's a Stakeholder Advisory Committee, which is meant to represent various professional councils, professional associations, entities, labor, etc. And the idea is for the minister to be able to get feedback on how the fund is actually performing, advise the minister about amendments that need to be made to the structure of the fund, etc. And so organizations such as SADA would fit into the Stakeholder Advisory Committee to share with the minister whether the benefits on dental care, for example, are achieving its objectives. There will also be patient groups that will be part of that. Moving now to the general provisions. Firstly, the role of the minister given this amendment to the structure of the health system. So the minister will remain the steward of the health system, but also will be responsible for the National Health Insurance Fund. So the minister will clearly identify roles and responsibilities between the fund and provincial departments of health. Because in addition to the amendments that are happening on the private sector side of things, there are also massive changes on the public sector side. So provincial departments of health will basically have powers allocated to them or assigned to them as management agents. So the powers of the health system will lie with the minister, and he will be delegating those powers based on the capacity of provinces. So the Department of Health at the national level will remain with guidelines for norms and standards, human resources planning, coordination of health services generally, dealing with issues such as licensing of health establishments, just the integration of annual health plans across the various provinces. And then to also allocate functions to provincial departments of health based on their ability to deal with that. We're also going to be designating hospitals as autonomous legal units. The intention is, as I said earlier, that hospitals become independent legal units, so they're able to operate independently of provincial or national government, be allocated a budget, report into to government about how they're delivering those services, rather than them having to get approval each time they want to actually access services or the like. So the other areas linked to the general provisions are the role of medical schemes. So as I mentioned earlier, once the national health insurance is fully implemented, and I'll outline to you what are the steps for full implementation, the minister will introduce regulations that limit benefits of services not reimbursable by the fund. So simply put, the intention is to say, if you're paying for this through the fund, then you shouldn't be then paying for this through your medical scheme. So the scheme will cover everything else that's not covered by the fund. Clearly, the fund is intended, as I said, to be a progressive approach. So in other words, the benefits that we'd start with would progress over years and expand. And so what we start with may result in medical schemes covering many things. And so over many years, you'll then find the extent by which medical schemes are covering certain benefits would reduce because the fund would be covering it. That obviously depends on our economic growth and what the fiscus actually allows. There would be a district health management office as well as a contracting unit for primary health care. These are two new structures in the health system because they weren't there before. And the district health management office, simply put, is intended to replace the provincial health department head office and bring that office closer to a district level. Very often, public health facilities are unable to engage effectively with their head office because they're too far away, and there's no understanding about what are the problems at ground level. So these offices are intended to engage with facilities and make sure that health services are being delivered as they're intended to in compliance with various norms and standards. The contracting unit for primary health care is effectively a representative of the National Health Insurance Fund at a local level. So a dental provider, for example, operating in a district shouldn't have to contact the head office of the National Health Insurance Fund to engage on any issues that may arise out of the contract. There would be a local office, which will be the contracting unit for primary care, that will manage that contract, make sure that reimbursements happen appropriately, make sure the referral systems are working, etc. Then the general provisions also deal with the Office of Health Products Procurement, and here the office will basically get involved in what we would call national procurement arrangements. So where you have a national provider of goods or equipment or medicines, etc., we would get into an agreement with that provider around what we would be able to purchase at what price, and then all of the contracted providers in the health system will then be able to purchase off the schedule at those agreed tariffs. The fund will then reimburse those providers based on those agreed tariffs that the Office of Health Product Procurement must be able to engage with. The idea is to negotiate a large purchasing deal so that we can get the best possible prices for the health system. Clearly, there'll be a formulary and it must respond to the burden of disease, any new medicines that may be available, or interventions and equipment where the evidence compels us to do so. Then there's the process of accreditation. So first is the Office of Health Standards Compliance that you may be familiar with, that all health facilities must comply with, whether national health insurance was here or not. And that will give every private provider and public provider a certificate for operation based on quality. Thereafter, those that wish to contract into the fund must then be accredited, and the accreditation looks at what are the minimum range of services, is there an appropriate mix of staff to deliver those services, is the equipment in place, will there be compliance with the referral pathways and treatment protocols, and to provide information to the fund around the type of patients that are managed and what's the outcomes linked to those patients. There'll be a contract that should be in place that would last 5 years, and the idea is to renew those contracts on a regular basis. Clearly, there would be some conditions around how contracts will be renewed. Where a provider has been refused accreditation, there's a defined appeals process for that as well. There'll have to be a very elaborate information platform, and the National Health Insurance Fund needs to be able to have information about what's happening in the health system, the quality of services, burden of disease, etc. And so the bill makes provision for that. It also makes provision that personal information of users cannot be accessed beyond the health facility itself. So all data for the purpose of planning, budgeting, etc. would be at an aggregate level so that information is protected. The bill then also makes provision for a payment of service providers, primary care providers being contracted through CUPS and being paid through that mechanism, specialists and hospitals having direct contracts, and performance-based reimbursement being part of the proposal there. The idea is that many of these payment mechanisms will need to be tested, and so rather than writing them in law now, we've deferred to doing much of this in regulation, given that we would need to obviously get into discussions with each of the professional groups of what would be a most appropriate payment mechanism, how that will happen. We need to test it to make sure it works. So writing it in the Act may be a problem because it's difficult to then amend. So we're going to put these in regulation so that we can amend them as we experience benefits and difficulties. So as I said, the fund also will deal with complaints and appeals. So where a complaint has been lodged and there is an unsatisfactory response to the complaint, such an individual can then raise this with the appeals tribunal. This tribunal has been given the powers of a high court, so it would be able to subpoena, etc., and will be able to reverse the decision of the fund without going through formal litigation processes in order to correct many of these things. So the idea is that the health system shouldn't incur high costs just for the sake of having litigation in place, and so we would be able to replace some of these issues through some sort of tribunal that we put up here. Financial matters, well, a lot has been said about this. So many people have asked a question, so where's the money going to come from? And the simple answer is from appropriations. Appropriations means that Parliament will basically be transferring money each year into the fund. It would vote an amount into the fund. We would go to the Treasury each year and say, this is the burden of disease in the country, this is how much of money we'd like. The Treasury would look at that and say, well, you'd like so much, but I actually can't give you that much, I'm going to give you X. So then trim your benefits to make sure that it fits in line with what we can afford, and that's what the fund will then put out each year. So the chief sources of income would be from general taxation, which South African Revenue collects. There would also be a redirection of funds that are currently being spent in the public health system, so what we call the provincial equitable share. In addition to that, there are conditional grants that provinces get, and so much of that funds will then be transferred into the National Health Insurance Fund. Additionally, the medical tax credits will be scaled down over a period of time, and those tax credit funds will then be transferred into the fund. And then Treasury is also looking at payroll tax as well as surcharge on personal income tax. And these, the Treasury have indicated, are the last two options. I'm anticipating in the next few weeks that they will come out with their paper. But the idea of the tax is to basically come up with something that is lower than what currently people are paying for the same benefit through their medical scheme. So our households should not be worse off through taxation than they were than what they're paying with medical schemes. So that's the cap on what the contributions would be. So we would obviously, as the fund, have to operate within that fiscal envelope, whatever that ends up being each year. The fund must be audited by the Auditor General of South Africa, and you must produce annual reports as required by Parliament, as well as the Minister, and also report on its performance, etc., which are legislative requirements for these Section 3A public entities. So let me just say a little bit about these transitional arrangements. As I said, the NHI is not happening next week or next year even. It's a process, and what we've outlined is what's happening in Phase 2 and Phase 3. There are a number of initiatives that must be in place, the most important of which is obviously that the public health system must be fixed in order for this to be delivered in an efficient and effective manner. And so in Phase 2, we've identified these what we call health system strengthening initiatives to deal with the issues of infrastructure, to deal with the issues of waiting times, staff attitudes, etc., so that we have facilities that are ready to implement the NHI. So the fund will start once we have facilities that have passed the Office of Health Standards Compliance Quality Test, and the office has started inspections of hospitals. You will hear maybe in the next month or two their initial reports of where our hospitals sit in terms of the range of meeting the standards. I was just talking to our colleagues from the UK. So we've borrowed the Office of Health Standards Compliance as a model very similar to what I think is called the Quality Care Commission in the UK. And so it's used a very similar model to understand what would be appropriate quality in our health facilities. So we would proceed with our legislation around the National Health Insurance. This legislation just entered Parliament now, so we anticipate a couple of years before this is finalized. Then there would be regulations linked to that, and I think that's where much of the detail about dentistry, for example, will come through. You wouldn't see that in the bill, but in the regulations that would come through. We will certainly start purchasing some health services before some of this happens through various financing mechanisms. So we'd like to focus particularly on vulnerable groups and go out to the various primary care providers, such as the dental profession, and say, we have this vulnerable group that we think we'd like to contract you to provide services. Can we talk about how we do that, etc. So that you'll certainly see us doing in this period between 2017 to 2022. We'll also be setting up various committees that must establish this benefit. So a tertiary services committee, a committee around benefits, a committee around health technology assessment, I think, which is very important in your space, about what technology do we adopt and fund, what don't we fund, how do we make these decisions. Migration of our central hospitals from provincial departments to become semi-independent structures, and then setting up these contracting units to engage with primary care providers in the community so that we can plan for the contracting process. And then understanding our public and private providers being accredited in time for this to start. There'll also be some amendments to other legislation. There's 12 pieces of legislation that must be amended to align with this act, and that will happen in parallel with this piece of legislation. And then the final phase, which is 2022 to 2026, we will then get into continuation of the strengthening activities, particularly in the public system. Then additional resources will be allocated by Treasury at that point, and there would be contracting of health service providers in the private sector in a much broader scale than what it currently is in phase 2. So these are the pieces of legislation that need to be covered. I'm not going, in the interest of time, I know I'm running out of time, so I'm not going to go through each one, but these are the 12 pieces of legislation that will be amended, because some of the clauses within these pieces of legislation contradict or conflict in some other way with some of the provisions that are in the NHI bill. Then finally, let me just say that the provincial departments of health will have new roles. As the Minister of Health takes greater responsibility of the health system and then allocates functions to provinces as opposed to how it's currently structured. So the Minister will delegate provinces as management agents, and this would require that provinces demonstrate their capacity to deliver a service, and there would be norms and standards by which that will be assessed, and the Minister may then be able to withdraw a delegation where a province is not performing appropriately in terms of that. The provinces have a responsibility in terms of emergency medical services, forensic pathology, etc., and so they will remain with those. The buildings, equipment, vehicles, etc., remain the assets of the province. However, the fund will be the funder of services. So, in other words, the service part of it will be lying within the fund itself. So, provinces would access those funds simply by patients accessing services and facilities. I'll stop at that point. Thank you very much. Should I sit here?
Thank you, Dr. Pillay. At this point, I'm going to just introduce the fellow panelists. We are going to take questions from the audience. I think we can probably do about 5 or 6. Don't be worried, because I have been informed that if you do have any questions that are not addressed now, please do email them through to the office, and it will... Casey will look at responding with those maybe in the next SADA newsletter that may come through, but he will get back to us on that. So what I would just like to do now is just introduce the fellow panelists. First up, it's Dr. Munyadizwa Albert Kwinda, who is the Ombudsman at the HPCSA, and he's followed by Dr. Ratten, who is the Dental Director at MPS, and Dr. Alasdair McKelvie, who's Head of Dental Services for Southern Africa for Dental Protection. I know we all have a lot of questions about NHI, but I think we do need to just take a step back and look at the knowledge base we have on stage, because For example, Dr. Ratten has been closely involved with the NHS over many years. So I think it's nice to get a global perspective on it as well. So do take the opportunity to ask those questions. So I would just like to ask everyone on the top, if you could, we only have one roving mic up there. If you could kind of get together, if you do have any questions, there is someone, just indicate that you do want to ask a question and we'll try to get to you. And this mic will be roving at the bottom. So are there any questions?
Lots of questions.
Okay, there's a mic over there.
Dr. Pillay, 2 years ago at our Congress in Cape Town, you indicated that there's a pilot program for this NHS. Has that been concluded, and is that data available for the stakeholders?
Should I take a few, or do you want me to answer each one? Okay.
The question is, having worked in the UK, there are options for patients to be treated privately, as well as they can take the choice to work have treatment on the national health system. Are you forcing all patients to go on the NHI, or do they have the option to go private as well?
My question is, there are 3 types of people: the unemployed, the middle class that is working, and the super rich, the fat cats. What happens to those categories? Unemployed people, no income. Those who have got income, and the super rich.
I'd just like to ask Mr. McKelvie why 86% of dentists are currently leaving the NHS in Britain.
Dr. Pillay, I have a question for you. Yeah.
Oh, hi.
You mentioned the word fiscal envelope. Okay, the fiscal envelope.
Yeah.
And of course, I want to ask you about the disconnect between the fiscal envelope and the pace of technological advances. How, in actual fact, will that be addressed and matched? Because during your talk, you mentioned that there are various committees that will, in actual fact, be monitoring, and they will be setting up guidelines and so forth. Would that not be more appropriate for the ones at coalface to be guiding that and informing that? Because the disconnect seems to be continuing, and of course, as the pace continues, it continues. And the gap just widens to the frustrations of the providers of service. Thank you.
Hi, everybody. I just want, actually, the first thing I want to say is, I don't agree with the idea that our whole board should be nominated by the Minister of Health, because I found out that politically that is suicide for the service providers. Because whenever there's a board, if you look at the NHS in Britain, that is purely nominated, they will end up doing things that are not in the interest of the private practitioners or the patients. They will work in the interest of the money that they have. The second thing is, I don't really trust your department to run this thing properly. Because firstly, I think there's a lot of people that are in the department that are anti-private practice. They belong to the old NAMDA group that were anti-private practice. They belong to the old SACO group that is anti-private practice. And there's no ways that those people always thought that we should be working in clinics, full stop. And free healthcare is free healthcare. It means that we get paid the minimum that you can, because that is why healthcare should be free, and it becomes a human right. Also, look at the pharmacies, what you did to the pharmacies, how you've decimated the private pharmacies, the black pharmacies, how you went into cahoots with people like ShopRite and Clicks and all those organizations. I always wondered to myself, how come that happened? Those people never gave you any money towards a freedom fight. Our pharmacies in the townships, they were destroyed, but you gave them money to the big boys, to the fat cats. And then you look at the life issue. Nobody has been prosecuted there. There's no real top boys that have really been hung up by the necks. You look at your hospitals and your clinics that are so inefficient at the moment. And you ask me, trust me. And I say, I cannot trust you. You put some of my members, you put some of our representatives on the boards of these organizations that you've got, and they can fight for us. And then I will say, yes, I can trust you. I know I have people there that are willing to fight for me. But this nonsense of having, if you look at even our HPCSA today, they have a certain trend that you see, and they are all nominated, and they sing to the master's tune because that is a job. So those are my two issues that I've got. So.
Okay, I think we'll give everyone an opportunity to answer. Do you want to go in any specific order, or I think we can maybe start with Dr. Pillay because
I had most of the questions. Yeah. So the question around the pilot programs. So there's a report on our website done by an independent organization, Genesis, and I think it's a consortium with WITS and others around the reports relating to the pilots. So the pilots were health system strengthening pilots. They contracted general practitioners to deliver services in clinics, particularly in rural areas where that didn't exist. They were involved with the centralized chronic medicine dispensing and distribution. They were involved with the district specialist teams, getting out obstetrician and anesthetists to support primary care clinicians in maternity, etc. So there's a detailed report of each of those activities. There were 10 kind of projects linked to that. And you can find the details of each project. The findings of the report, if I can summarize them, basically says that each of those projects should continue. There are certain districts in the country where those projects were less successful because the way the health system is structured doesn't lend itself for that to be implemented. But it's on our website, and it's a 80-page document, but you're welcome to have a look at it. Secondly, on the forcing patients to be in the NHI. So patients will choose where they want to go to. They would contribute into the fund. And thereafter, if they choose that they don't want to participate in the NHI system as such, they can do that on their own. That there's no obligation on them. But it wouldn't make sense for them to not choose the GP they normally go to access care, or the dentist that they normally go to access their dental care, and want to now go to the same person and pay out of pocket or through their scheme. It wouldn't make sense. I wouldn't understand it. But I mean, they're free to do that, I suppose, is legally. But I mean, economically, I'm not sure if that would make sense. How would we deal with the various economic groups? So everybody under NHI is equal. So in other words, I'm the same as any other person, whether my economic status is higher or lower than him or her. So the idea is that everybody gets benefits based on their clinical status, not on their financial status. And that's the difference that the president keeps talking about, that he would like to have the day when he's sitting in hospital and he's sleeping right next to a laborer that earns 1/10 of his salary, but they both get the same health care because health should not be a differentiator based on income. So that's the way the system will operate, which is a bit different from the way it is now. The question around dentists leaving, I think maybe you would probably deal with that. Around the question about the fiscal envelope, yes. I mean, every country can never keep up with what the innovations are. And so in the UK, you have NICE, and we have borrowed much of those learnings in establishing what we call the Health Technology Assessment Agency. And what this would do is go through a process of evaluating each of these interventions in technology and understanding what are its benefits, what are its costs, relative to the health system. Can the system afford it or it can't? And so in that process, you'd obviously have to bring in clinicians and people that are working on the ground, etc., because that's part of the process. And now it's a very elaborate structure that does that and helps the UK design what would be an appropriate benefit. I mean, there are obviously challenges with that as well, but it works better than what we currently have in South Africa. I hear the issues around the board. I think there is a process currently where Parliament is going to be publishing the bill and the public will engage. So I would encourage you to share your views. But let me just give you an analogy for the logic that we used in coming up with the way the structure of the board is currently. You have a Minister of Health who effectively is like the CEO of a company. And a CEO of a company should be able to employ his or her staff to deliver the service or whatever it is that he or she has to do. And he or she should be able to choose those people. If you're saying that somebody else must do that for the minister, the question is, who would it be that would be in a better position to understand who those people are? The alternative that we've heard is Parliament should do that. And the question is then, is there a better experience when Parliament did that? And I've not seen evidence of that, because the one example where Parliament does do that is in the case of the SABC, which is not a great example of how boards have functioned, right? So simply saying that Parliament does it doesn't solve the problem. Maybe we need some checks and balances about if a minister does it, there should be other things in place. But many countries use this approach of a public process, so the public can engage with it, public can respond and say, well, Anban Pillay applied to be a member of the board. The public think he's absolutely useless. He should never be in that post. And so then the minister has to take account of those kinds of things, right? So it becomes more public as opposed to saying, well, Parliament does that, because, I mean, I'm not quite sure if they necessarily would do any different a job. So, yeah, I think on that issue, I'll stop there. Thanks.
Thank you, Dr. Pillay. Dr. McKelvie?
Yes. Thanks, Willem, for the question. I mean, I think that I'm glad Raj is here, because I know more about dentistry in South Africa than I do about dentistry in the UK now. And he's a bit of the NHS expert. This is a fairly difficult question to answer, because there's a number of different complexities to the answer. And the question is, why are so many dentists leaving the NHS in the UK? There is a question that goes with this about, which it probably gets more publicity, is how difficult it is for patients to find an NHS dentist with the capacity to see them, which is sort of along the same lines. Now, the answer is not straightforward to your question. There are a number of complexities. I think that dentistry and primary care in the UK has changed with corporatisation. And the number of practices that are owned by individuals has dropped, and there's been this creeping corporatisation of dentistry in the UK, which in itself provides security of employment for dentists, but creates different pressures and targets that you wouldn't place upon yourself if you were running your own business. So that would be one of the reasons why there's a change in the demographics. I think the other thing is that there may well be an influence here around Brexit, because we had a huge influx of European dentists into the UK. And we know from our own membership that the European dentists have done their time in the UK, and they're moving back to their own countries to open their own practices. So that may well account for the differences in numbers. I think that the NHS is a difficult system to work in, and this is more of a personal opinion, because if you ask most of the dentists in the UK working in the NHS, they will be seeing between 20 and 30 patients a day, probably many more than that, and in some cases seeing 70 patients a day. And I mean, apart from being the quality of care suffers there, I think that what we're seeing is that dentists can't continue to work under that level of pressure. We get the burnout that we were talking about and looking at, and we just get people leaving the NHS because they can't hack it any longer, and they opt for the security of the private sector, or they go overseas. So, I mean, those were the answers that immediately come to mind here, but I think that pressure of work is probably the greatest danger to the NHS dental system in the UK capsizing. Raj?
Thank you. I think you underplay your expertise, Alasdair. It's a very comprehensive answer. Can I just first say that the last time I was on a panel on a stage was actually in South Africa a few years ago at the Ethics for All conference, and I was called up onto the stage, and there were chairs on the stage that had arms, and I had a little bit of difficulty sitting down. And then when I tried to get up, the chair wanted to walk with me. So can I just say I'm really pleased that these chairs don't have any arms, and I'm here sitting quite comfortably. So thank you for that. The gentleman that asked the question, sir, I don't for a moment doubt the integrity of your question. I fully understand it. What I would first of all say is this. I think the figure of 86%, which was quoted, clearly that information has come to you through some source, be it written, personal correspondence, whatever. I think that is a slightly misrepresented figure, because that's not my experience of working in the UK at all, and we work with an awful lot of dentists. It may well be the case that 86% of dentists would like to leave the NHS, yeah, but that's a different statistic to the one that says 86% of dentists are leaving the NHS. So I think it's important just to clarify that. So in terms of what the pressures are, I'll try and list them in addition to the ones that Alasdair has mentioned. Now, first of all, there's a root cause. In other words, one cause that is responsible for multiple people wanting to exit the system. So the first thing we have to identify is, what is the root cause of the angst that is driving dentists potentially away from the NHS. And the root cause is that when you're a clinician, whether you're in medicine or dentistry or in any sphere of healthcare, as a clinician, you are trying to balance in a system that you're working under commercially, you're trying to balance three variables. You're trying to balance time, quality, and money. When there is a constraint in any system, and in a state-funded healthcare system, the constraint will be money. You can only deliver 2 out of 3 of those elements. And that is the root cause of the problem. Okay, and we must also understand that governments have a responsibility to use taxpayers' money wisely. And however much we would like the government to pay for our patients to have their teeth whitened, there are other healthcare priorities that have to take priority, have to take precedence over our wishes for dentistry. So the consequence of this is that dentists get frustrated with the system. Secondly, in the UK, in 2006, we had an evolution of our previous NHS payment system. We now have a system where the unit, the currency of performance, is what's called the unit of dental activity. And we have a system that will pay a practitioner the same amount of money for doing one restoration in one course of treatment for a patient as another patient who might require 5 restorations. That's a little bit like saying to an architect, build me a 20-story building, I will give you the same fee whether you put in 1 window or 3,000 windows. Yeah, you will get a brick-built construction with a single window. Okay, so that payment system is flawed and it's driving inappropriate behaviors. The other couple of things I'll mention, and this is the reality, and we have to accept this as well. The aspiration of young dentists in the UK is to own their own practice for many of them. Practice values in the UK since 2006 have gone up approximately 7-fold. Therefore, the young dentists are gearing themselves very highly in order to be able to afford the practices that they wish to own. The consequence of that is that they're heavily borrowed and they're having to meet significant repayments. As a result of that, they set themselves unrealistic targets to hit. It is a self-imposed pressure. Yeah. So we have to recognize that as well. And then the last thing I'll say is, in the last 5-6 years, in real terms, there's not been an increase of fees, because in the UK, we've had what's been called an austerity program implemented by the Treasury. Healthcare has received minimal increases in funding year on year. And if you look at the earnings of dentists today in terms of the gross fees that are generated, in real terms, they're probably down somewhere between 10 and 15%. Because the cost of materials is going up, the cost of infection control is going up, we have single-use disposable endodontic instruments, and the costs of the business are getting higher and higher, but there's been no state funding increase because the UK has gone through an austerity program in terms of its sort of finances. Okay? That's just adding further pressure to it. But all of these reasons, you can track back to the time, quality, and money trilemma. And that will exist in any healthcare system anywhere in the world where you have a constraint. So it's not about whether this government is implementing something that's unfair or that government's implementing something that's unfair. It's a feature of the system across the world. And I will just make one other point, which I thought you made very well in response to the question about will the super rich be treated as the poor? From an ethical point of view, if you look at any definition of quality in healthcare from any commentator anywhere on the planet, equity appears in every list. The importance of treating everybody equally. And it is fundamental for governments to do that. It is an extension of the greatest good for the greatest number. And if some of you are slightly more commercially minded, and those of you that were in my presentation yesterday afternoon will remember the quote, yeah, you read the book called Carl Sewell, which is a commercially driven book about keeping customers for life. He offers the business community 5 golden rules. Rule number 3 is treat everybody with equal respect, irrespective of their health, irrespective of their social and economic status. So whichever side of the line you're on, the principle is sound and remains solid. Thank you.
Thank you so much. Just because we are very short on time, I apologize to Dr. Zirkle already. I just maybe, Dr. Kwinda, is there anything you'd like to add onto?
Nothing to add, please. Thank you.
All right. I am very sorry that the session wasn't longer. I wish it was, and I wish I could create more time. But please do not feel disadvantaged if you haven't asked anything that you do want to. As I did say earlier, you can send it through to the office, the head office. I would like to once again thank all the panelists. I think we are going to leave here with a bit more clarity than we had. But I think it's such a big event in our lives that it's always going to get a bit confusing, and this regular reassurance and I think further investigation into it is always good. I'd just like to award 2 prizes. Dr. McKelvie and Dr. Ratten are talking later on during the course of the program. So I just want to please ask Dr. Pillay and Dr. Kwinda to come up to receive just small tokens from SADA.
Thank you very much. Thanks.
Okay, just before everyone rushes out, please go onto your app and go to the polls. Can I just please get them up on the screen quickly? Okay, so there's 2 questions that need to be asked, and it's question 5 on your polling on the app. It goes, sorry, question 6. It's question, not question 5. Question 5, sorry. Okay. Why do you attend a SADA Congress? And then you can choose as many of the applicable answers. Can we do that at the moment? And we're going straight into the next lecture, so please, can we afford the next speaker the respect due to him? Please do not rush out as well. Okay, can we get the answers up for that? Okay. Just to quickly go through it, so everyone wants CPD points and professional development. Networking also features. So that's the main interests that we have at a Congress. Equipment, a holiday. Well, the weather hasn't been so kind to us this time. Question 6 as well. Can I just get question 6 up quickly? Do you know what NHI is all about after this? You can enter your answers. There's only one. Maybe. We're getting there. Oh, well, yes, 38%, right? So slowly getting there. The final one is, how many hours do you work per week? That's question 7. Okay, so that is 33% of people work 40 to 44 hours. And then we've got some very hard-working people, 45 to 49 hours. Okay, so I want to know, who's this 1%? Okay, well, that's my aspirational goal. All right, now it's my pleasure to bring onto stage Dr. Christoph Zirkel. I apologize to him profusely for delaying him. Dr. Zirkel studied dental medicine at the Albert Ludwigs University in Freiburg, Germany, and received his